Good evening to you all. Welcome to this instruction course on optic disc for postgraduates. We're slightly delayed because of the previous session. So this is going to be some tips for the postgraduates how to take it clinically and what important investigations you need to do. So it's basically PG based, and I hope you will get a lot of interesting points. First, Dr. Saravanan will talk about AON as he is going for another session as a judge.
Thank you, sir. Slides. Yeah, thank you. So this is quite a common scenario which you notice when you're doing medical retina practice. And first question is when you see a disc edema, what are the DDs to think about? But I'll mainly be talking about AON, and in the following speakers will enlighten you on how to differentiate between all these entities. So as you know, this is very commonly seen in the old age group. And when we have multiple risk factors, systemic risk factors, diabetes, hypertension, cholesterol, heart disease, and all those things. And most common thing what we see is the non-arteritic type, which is a little bit less aggressive compared to the arteritic type, which is much more rarer. And we don't see that very often, but you need to keep that in mind. And in case you have better to refer to a higher center because these patients need a lot of long-term follow-up also. As I told you, the vision can be usually is what we see in our practice is that the vision in these patients with the non-arteritic anti-ischemic optic neuropathy is usually 660 or less. Occasionally, you can have patients who have vision better than that, but most of the times, if you have vision more than 660 or 636, keep other DDs in mind before you narrow it down to a NAON. So this is just a few case examples. This patient actually came a little bit late after around 6 weeks of vision loss. And we noticed that he had disc pallor and RAPD in the right eye, and he was a known hypertensive and not on continuous compliant treatment. He was a little bit irregular in his treatment, and he was complaining of altitudinal field defect. As you can see here, the left eye, it has got a very small cup or no cup in the left eye, but the right eye, when you notice, you can see that the inferior disc is a little bit more pinker, but the superior half of the disc is much more paler, with also some arteriosclerotic changes, which is maybe because of his hypertensive retinopathy. So this case, then finally we worked up, and all cases, first you rule out that the ESR is normal, and in case you are doubtful, always do a CRP. And because he was a known hypertension, he also had cholesterol also. So we didn't further investigate him because of old patient, and we just treated him conservatively. This is one more case where I failed to identify the patient's diagnosis. A young patient who's coming with had mild hypertension, mild dyslipidemia. And he came to us with the one disc. He had around 260, 360 vision in this eye when he came. Left eye was a small disc, and the right eye was, you can see, as you see, you can see the pallid disc edema. Look at the margins, you can see the pale color. So there's a pallid disc edema on one eye, and in a very young and healthy person who's got a very mild systemic or a very low risk factors, mild hypertension, mild dyslipidemia. So unfortunately, even though I referred him to I was sure that I was missing something, so I referred him to the internist, medical specialist. But unfortunately, they didn't pick up any systemic disease at that point of time. But he came after around 1.5 to 2 months with the other eye involvement. Again, vision dropped to around 460, 560. And then I referred to another physician, and they diagnosed that he had a factor V Leiden deficiency. Unfortunately, I felt so bad because I had missed it around in the first sitting itself. But there can be unusual reasons in patients with the anti-ischemic optic neuropathy, especially when you feel that the risk factors are not pertinent enough to cause such a big manifestation in the fundus. So always keep other rare DDs in mind when you are dealing with these patients. So almost always, depending on the vision acuity loss, you will have a disc edema and RAPD. And usually field defects are altitudinal, but not always so. So don't give too much importance to the altitudinal field defect. You can get irregular fields or very poor vision where the patient is not able to see the fields also. So a significant number of people, around 1/4, will have some sort of pain in the eye or the head, which can be a little bit confusing with the optic neuritis diagnosis. But again, there are other factors where you can narrow it down. So one thing which can a little bit mimic NAON is amiodarone. I have seen one case of amiodarone optic neuropathy, which I wrongly diagnosed. But the disc edema was persisting for normally in AON, the disc edema will resolve within 3 to 4 weeks and pallor will set in. But this case had persisting edema, and finally, after reading up, we finally diagnosed that patient was on amiodarone, and it was the reason for this neuropathy. So when you do fluorescein, normally we don't, it's a more of a clinical diagnosis, but occasional case where you're doubtful, you can do a fluorescein angiography. And in the fluorescein angiography, like in this case, when you see, you can see the superior black area, meaning that the disc is not filling up in that area, and that's why the patient also get a 6 altitudinal field defect, as you can see here. So this is a corresponding altitudinal field defect, and once it resolves, it will go on for a pallor, approximately 3 to 4 weeks after. Definitely after 6 weeks, you will see that the pallor is already set in. Any edema persisting more than a month, be wary of a diagnosis of NAVN, but it's unusually not usually AVN at all. So if it's persist. There's one more case of so you can say typical superior disc, half of the disc is pallid disc edema, and fluorescein is showing the filling defect. It's a diabetic patient, again a case of NAVN. So in OCT, normally you will not see macular edema in these patients, but a small percentage of people can develop peripapillary thickening, papillomacular bundle area thickening, and sometimes a small SRF in the macula, but it's not common. So in case you have a significant macular edema or SRF in the macula, think about other inflammatory DDs, which should probably be discussed in the coming speakers. So you can see here the disc edema in this patient. The OCT is showing the disc edema, and you can see the papillomacular bundle area edema, as well as a short, small SRF in the fovea. But this is not a common finding in AVN, but occasionally it can happen. So one other DDs which you commonly confuse is the optic neuritis, and you can see that the field effects are not usually opposite to each other. And the thinning which you notice in the optic neuritis also is a little bit different from what you see open angle glaucoma, and what you see in the NAVN are totally different here. So this is a case of resolved bilateral NAVN, the light in the NAVN, and you can see the OCT angiography shows the loss of the capillaries on the surface of the disc. Compare this to the left eye, and you can see the right eye that surface capillaries have lost out. So sometimes OCT angiography also will help you to clinch the diagnosis. So this is a case of a young female who came to the disc edema. Again, somebody had diagnosed, because the patient was already hypertensive and diabetic. They are diagnosed NAVN, referred to the clinic. But you can see here that there's a small NVD, and also you can see the cystoid macular edema pooling in the late phases with multiple areas of perivascular leakage in the periphery. And if you do the OCTA, you can see the NVD sitting there. So when you see NVD, it's usually almost always inflammatory disc edema, and this patient turned out to be a sarcoid patient, and then went on for a steroid therapy also. So the other things to when diagnose AVN is to rule out the cause, because treating the cause can prevent the occurrence of such eventuality in the other eye also. So common causes are like disc at risk, which you see, and apart from that, the routine vascular diseases like hypertension, diabetes, sleep apnea, and post Viagra, a few cases have been reported, and hypercholesterolemia. So all these can be risk factors, and addressing these risk factors will go a long way in preventing the same occurring in the other eye. Other rarer causes to keep in mind when the routine workup turns out negative is all these inflammatory diseases of the vessels, and also factor 5, which I missed out and I showed in one of the cases. So blood count, routine blood count, and is enough in routine old patients with other significant risk factors. But if you're seeing young patient or unusual finding, always work for other immunological diseases also. And first thing you have to do is always ESR and CRP if needed to rule out the artery type. Because if you're seeing artery type, the treatment is going to be totally different actually. So this is just showing the difference between a normal disc and a disc at risk, how the difference is. So the disc at risk means that the other eye is also at a higher risk of developing NAVN. So the treatment as far as NAVN is concerned is not very great, as till now we don't have a very proper treatment for this. And the decompression trial, they showed that it was not very helpful. Initially there was during my PG days there was a lot of interest in the decompression for NAVN, but again it turned out to be not very definitive treatment. Right now we don't have any treatment, but addressing the systemic risk factors and probably taking aspirin also can help preventing the other eye getting affected. In artery type, the picture is a little bit different. You have significant systemic symptoms, and it's usually a little bit more higher age group, as you can see here. And the disc edema is much more profound, like you see in this patient. And you can see the presence of jaw claudication, malaise, sometimes myalgia, sometimes mild fever also can be noticed. So normally we to clinical diagnosis, previously we were doing the temporal artery biopsy, and usually the ESR and CRP are quite high. But recently, the MR imaging of the temporal artery vessels can also pick up within a non-invasive way. The specific gravity, so the specificity of this test is almost 90%. So if the MRI of the temporal artery is negative for occlusion, then usually it's not temporal arteritis. So now the artery type, without the necessity of doing a temporal artery biopsy, now MRI imaging of the temporal arteries, scalp arteries and intracranial arteries also can clinch the diagnosis in these patients. So in case you diagnose this, better to refer to a higher center, because ophthalmology we don't have that much of the backup to treat them, because the treatment can go as long as 1 to 3 years or more than that also. So high dose steroids initially, followed by non-steroidal immunosuppressive drugs like methotrexate and other things need to be addressed in these cases. I'll stop here. Thank you for the opportunity, sir.
Thank you, Dr. Saravanan. Dr. Saravanan is the head of VR department at Aravind, Coimbatore. Next, I invite Professor VR Vijayaraghavan sir from Coimbatore to talk about optic neuritis.
Good evening. Thank Dr. DC for this great opportunity. Are there any PGs are here? I do not know whether PGs are not. All are PGs. Don't worry. Okay. See, optic nerve is not a nerve. Please remember that. It's only a wide fiber tract connecting second order ganglion cells and the neural axons going up to the LGB. LGB is a third order neuron in the visual systems. That's why it is not a nerve. It's only a wide fiber tract. And moreover, it has got no neurolemma. That's why when you have an injury, it will not regenerate. Unlike in the case of third nerve, fifth, seventh nerve and all, you got aberrant regenerations, which can never occur in optic nerve. That's the reason if it gets damaged, you cannot recover the vision. That's the most important point. Then we have got isolated. What is isolated optic neuritis? Inflammation of optic nerve again. But when you are not having associated multiple sclerosis, when you are not having any other problems associated, systemic problem associated, you take it as isolated. But you cannot leave it like that isolated, because this fellow may land up in multiple sclerosis in future. That's why you have to follow the persons properly. That's why I told you, optic neuritis, whenever a patient comes to you, always follow him forever. The reason is he may develop multiple sclerosis, so many complications in future. There's the importance of optic neuritis. We are going, because the patient will come to us only with a visual loss. We are diagnosing, but don't leave the patient. At least tell him to follow up, or at least let him go to neurologist for further evaluations. Based on topography, normally we tell what now, optic neuritis, axial neuritis, mainly the macular fibers are involved. There's you got a central scotoma. But central scotoma is one of the most common problem as a clinical or field defects you can expect in optic neuritis. But never forget, it's not the only thing. We can have even contraction of fields, because periaxial or peripheral fibers are involved. Or I can have a transverse neuritis also may develop. That's why central scotoma is not the only feature for optic neuritis. You can have any type of field defects, you can get it. That's the reason for this, because of topographical involvement. Ophthalmoscopically, you see disc is involved, papillitis. Okay, irritable neuritis, that means patient sees nothing, you are also not seeing nothing. That's called irritable neuritis. Whereas one neuroretinitis is there. Neuroretinitis, we can have hard X-rays in the maxilla and all associated with papillitis. We call it as neuroretinitis. Now, etiology. I'll tell you most important point. The most common cause for optic neuritis or irritable neuritis is demyelinations, multiple sclerosis. My advice is that sometimes for postgraduates, they will ask you questions. What's the most common cause for neuroretinitis? Never tell multiple sclerosis, because we do not have myelin sheath in the retina. That's why we will never get neuroretinitis in multiple sclerosis. It's a normal person. I can have myelin sheath abnormally, that's different. But myelin sheath in the retina is absent. That's why neuroretinitis cannot occur because of demyelinating problems. It's the most classical exam question for you. Then we have got para-infectious. What is para-infectious? That means I got vaccination to the patient. Patient develops neuritis. That's called para-infectious. Infectious, we have got tuberculosis, syphilis, so many infections are there, viral infections, so many things are there. They are all coming and be infectious. Whereas non-infectious, classically you should know something about sarcoidosis. Sarcoidosis, of course, rare in our country. In our country, it's rare. But normally we may be missing the problem also. We think as if it's a case of tuberculosis. That's why we may be missing the problems, but usually non-infection means sarcoidosis. I told you. Para-infectious, I told about following vaccinations. These are also okay. Infections, I told you, bacteria and all these things. Here, always remember, one thing, common question is what? Sinus related. We will ask in exams for postgraduates, which sinus is notorious to produce optic neuritis? Our answer should be sphenoidal sinus. Because sphenoidal sinus is in close relation to optic canal. That you say only thin bone is there. So naturally a sphenoidal infection can involve optic nerve. That's why optic neuritis, commonest source of infection, just which sinus means answer should be sphenoidal sinus. That is called what is called as Van der Hoef sign. That's called as Van der Hoef sign. Sphenoidal sinusitis involving optic neuritis, developing signs and symptoms of optic neuritis called Van der Hoef sign. Van der Hoef. Just remember some of the things. Other things we like syphilis, Lyme disease. You know we have got Borrelia burgdorferi. So many infections are there. Then cat scratch. That's called Bartonella. These are all some of the bacteria a PG is supposed to know. Sarcoid. If you are asked the classical exam question is what? The disc appearance. Lumpy and bumpy. Lumpy and bumpy disc. You can have granular mass in the disc. You can have, that's called lumpy and bumpy disc in the case of sarcoid. But one more question will ask you, which is the other condition where you can have a lumpy bumpy disc? Your answer should be drusen of the optic nerve head. Drusen. Neuroretinitis, I already told you, never tell. Your answer is demyelinating problem, cannot, should not tell. Whereas other conditions like cat scratch, Lyme disease, mumps, these things can produce neuroretinitis. Never forget that. Now, classical what? Patient comes to with demyelinating problems, usually unilateral, unlike papilledema, maybe bilateral. Whereas here, female sex more common, between 20 and 40 years. Very rarely, I'll tell you, very rarely, I told you, optic nerve, you will have visual loss problem, visual reduction may be there. But very rarely, you can have a 6-6 visual vision, that's called 6-6 optic neuritis. That can happen where? Only when the maxilla fibers escape. That axial portion is not involved. You can have a 6-6. That is called 6/6 optic neuritis. Just know this. That's called 6-6. What are the symptoms? Loss of vision, of course. Loss of vision is there. Pain on movements. Elevation and adduction is a classical exam question again for PGs. On elevation and adduction, patient will experience pain. The reason is, so superior rectus and middle rectus tendons have got attachment to the dura mater of the optic nerve at its origin. The optic nerve is inflamed. So when these muscles contract, they can pull the optic nerve. Naturally, they can experience pain. That is called as Whitnall hypothesis. It's called as Whitnall hypothesis. Without sign, that means when you increase the body temperature of the patient, demyelinating problem is there, optic neuritis is there, multiple sclerosis, you increase the body temperature, the vision may be coming down again. Suppose my vision is 624, it will come to 660. The reason is, see now there are so many reasons for Uthoff's phenomenon. When you have a problem of increasing body temperature, we produce some chemical substances in the demyelinating areas, which can inhibit the further message. Whereas one more thing is that, we have got demyelinating plaques are there. The plaques around the optic nerve, when they increase the body temperature, doing exercise and all, they can become edematous. When they become edematous, they can compress the axons. So further problem can occur. That's the reason. Uthoff's sign is because of edematous plaques compressing the optic nerve, which can occur in a patient with a demyelinating multiple sclerosis. It's called Uthoff's sign. One more important point I'll tell you. Suppose you are having optic neuritis case. Okay, normal demyelinating problem is there. Normal circumstance. Within 2 or 3 weeks, you should improve. If it is not improving, the vision is not coming down. It's normal circumstance, I'll tell you. It has to improve. If it is not improving, that means it's not the case. You are dealing with something else. Maybe you are dealing with some compressive lesion. We do not know. That's why always remember, a first time optic neuritis patient you are diagnosing, it should come down or it should become normal at least within 2 or 3 weeks. If not, be careful. That's all. This is what normal now conductions. You see now myelin sheath is absent. You can see the conduction getting delayed. Can you see these delayed conductions? This is what's happening in optic neuritis. Signs, visual acuity reduced, I told you. Pupil RAPD is there. Know that. RAPD is the relative apparent pupil defect. Can you see now here the right eye pupil constricts and you put the light in the left eye people dilating. Now come back to right is constricting. It's called left eye has got RAPD. Never forget this. Left eye has got the most common cause for RAPD is optic neuritis. But we have got so many problems in the retinal movement, CR occlusion, vein occlusion, so many things can happen. RAPD can be there. One important question for postgraduates. Whenever you have got, suppose in this case left eye optic RAPD is there, never forget to tell in the exam, suppose you are asked, optic tract in the other side. Always remember, optic tract is involved means opposite eye will show RAPD because the nasal retina is going there. Your nasal retina is excess. Nasal retina is very important for our pupillary reactions. That is why nasal retina in the left eye is crossing into right tract. So the right tract is involved, I can have a left RAPD. Always tract involvement will produce contralateral RAPD. These are what common exam questions again. Full feature, of course. Color vision, contrast, everything is there. Problem patient can have optic neuritis. But now the field changes. The central scotoma is there. The question is what? We will ask in exam. In Humphrey field analyzer, when you have a central scotoma, how do you proceed? Because the fellow cannot see the light in the center. How do you proceed for the testing? Because patient cannot fix the target. Your answer is, sir, I am having a diamond target. Large diamond is there. You ask him to fix inside the diamond. I can proceed. This is a way the question. Suppose you say the chart, Humphrey chart, you see the fixation target, diamond. That means he is having central scotoma. He is having optic neuritis case. Or a central scotoma is there. That's all. Very simple to see from the chart itself. Okay. Of course, Jerem screen all we are not using nowadays. So no problem. Understand now? I told you already fixation target. Whenever you had a children problem, bilateral optic neuritis means always you are dealing with the infections. Never forget that. Slit lamp, you have to see for cells in the vitreous. Then fundus, of course, hemorrhage and exudation near the optic disc may be there in a case of optic neuritis. AION, already Dr. Saravanan told about temporal pallor and all, maybe there in AION. Understand now? This is what disc is hyperemic, margins are similar to a papilledema only. Never forget that. Maybe the problem is what now? We can have visual losses. Papilledema patient may not have visual loss, that's all, usually, unless he develops optic atrophy. Otherwise, optic neuritis patient will have visual loss, whereas papilledema no. Papilledema usually bilateral, optic neuritis usually unilateral. Never. These are some of the differences they will ask you. And papilledema can have enlargement of blind spot. Optic neuritis can have central scotomas, like that field effects. These are some of the, and RAPD is that people, whereas papilledema people may be normal, unless a problem occurs in late stages. Understand now? These are some of the differences we'll ask in exams. And never forget to rule out different compressive lesions. I'll tell you one important point. Suppose I'm having optic neuritis, like some optic nerve problem is there. You think RAPD is there. Understand now? But the problem is what? I can have a post-fixed chiasma. Post-fixed chiasma is there. Post-fixed, that means pituitary enlarging. It can come as optic nerve. They can develop optic nerve problem because the chiasma is moved backwards. A long optic nerve is there. It can compress the optic nerve. It can produce problem for the patient. That's why whenever you see optic nerve problem or something, visual acuity problem is there, you think optic neuritis is there, something optic nerve is involvement, never forget to ask for MRA so that you can see the pituitary lesions. Otherwise, you will be missing the pituitary lesion. Understand now? That's why the most important point. Why do you want to investigate? Rule of the compressive lesion, main aspect. See, everyone knows multiple sclerosis, they can also treat. But the most important point, you have to rule out a compressive lesion so that you can life-saving problems. CT scan, MRI, the most important things. Understand now? Other things like other investigation. Suppose syphilis means I have to do some investigation. Tuberculosis, you have to do some investigation. Like this. X-ray just means you have to rule out for some sarcoid and all. That's some of the investigation you're supposed to. But never forget the CT scan, MRI to rule out what? Some brain tumors or something. Of course, nowadays they have been told now BT101. This fellow, key female fellow, if they are having this, they are notorious to develop multiple sclerosis in future. BT101. These are some of the studies concerned with optic neuritis to get the treatment. That means mainly for the multiple sclerosis. All of you, the PG should know this. CHAMPS means controlled high risk AVANX. AVANX means interferon beta 1A, multiple sclerosis prevention study. ETOMS means early treatment of multiple sclerosis study. Here also they were using interferon beta 1A only. It's called AVANX. Champions means ongoing neurological surveillance. I have given AVANX treatment. I want to follow him further. What's happening with the patient? I'm going to take a MRA, keep on doing MRA, like that, keep on following the person, whether the fellow develops multiple sclerosis or not. That's called champions. Benefit means interferon beta 1B. That's called beta seron in newly emerging multiple sclerosis. Benefit. These are some of the names. Just know this. These are some of the studies they have gone undertaken along about the optic nerve role of interferons in the management of optic neuritis to prevent simple multiple sclerosis not. Okay, that's why what's the idea I already told you. Optic neuritis patient comes to us first, you investigate, you find out the problem. He may develop in future multiple sclerosis, so that accordingly you can refer the patient so that you can save the patient from dreaded life. Understand now? Thank you very much.
Thank you, Dr. Vijayaraghavan, for that wonderful talk. Next, I call upon Dr. Chandrasekhar D from Aravind Eye Institute, Coimbatore, he'll be speaking on papilledema.
Very good evening to you all. So I thank the organizing committee, scientific committee, and Dr. Baston for this wonderful invitation to conduct this instruction course, and thank all my co-speakers, Dr. Vijayaraghavan sir, Dr. Saravanan, and Dr. Kalaimadi for joining us. So next 10 minutes, I'll give an overview of papilledema. The eye is the window of the body as per Leonardo da Vinci. So this is the only place where we can see live the blood vessels and the nerve. Excuse me, sir. Sorry. Okay. Blood vessels and the nerve. So it gives lot of clues not only to the eye problems, to the problems elsewhere in the body also. Here you can see it is one of the eyes which you could not, take it for transplantation. We can see what I am trying to do. What is this? The optic disc is appearing elevated, isn't it? So first they saw this optic disc in people who were dead. So there everything becomes edematous and it was elevated. So that is why the misnomer, it is called papilla. It is not actually elevated. Other terms have been strong papillae, choke disc. So actually Von Graffi first reported disc changes in a case of brain tumor. Parson only coined the word papilledema, but it was these Patton and Holmes who said all edemas due to raised ICT. They are only called papilledema. With inflammation, they are called papillitis. So that is the terminology. The other thing is called plerocephalic edema, disc edema with raised intracranial tension. You know about the circulation of the CSF. So causes for raised intracranial pressure could be many. Any space occupying lesion, blockage in the ventricular systems, obstruction to CSF absorption. So many things as shown here, including hypersecretion of cerebrospinal fluid. So there have been many theories that have been proposed for how the papilledema develops, starting from inflammation, vasomotor theory, venous engorgement, so on and so forth. But ultimately what is most accepted is the our own Sohan Singh Haire, who said it is the axonal transport mechanism, orthograde axoplasmic flow is affected, slow component. So this is the pathogenesis of how papilledema develops. So etiology for disc edemas could be ocular causes and orbital causes. They are not called papilledema. So acute hypertony, CRVO, and all space occupying lesions of the apex will cause disc edema, but they will not be called as papilledema. Here again you remember not those papillitis and AO1, they don't come under disc edema. You can call it pallid edema, but these are the ones which I told are ocular causes and orbital causes. All papilledemas are disc edemas, but all disc edemas need not be papilledemas. In intracranial causes, all raised ICP, intracranial pressure, tumor, abscess, any space occupying lesion, including a syphilitic gamma hemorrhages, and meningitis can cause that. Cranial abnormal oxycephaly, that can be because of improper fusion, CSF changes like Landry-Guillain-Barré syndrome, and idiopathic intracranial hypertension and tumors of the spinal cord also can cause papilledema. Systemic diseases like including our main, it can be one of the important findings when you get hypertensive grade 4 retinopathy. That means patient is in a very critical stage. So in disease of unknown etiology like sarcoidosis. So here you are seeing something on the right eye and the left eye. One is edematous, one is looking normal. So where all you can get unilateral papilledema. First thing you will always think about is the syndrome, but you remember ICT is lower, intracranial pressure is lower on one side, you will get initially one side. Excess glial tissue on one side, optic atrophy has occurred in one side, normal disc one side and atrophic disc as I said. Then blockage of intervaginal spaces on one side, and this is the one which you will all think. What do you see? One side it is edema, one side is optic atrophy. Ipsilateral optic atrophy, contralateral papilledema, and anosmia. Only if anosmia is there, it's a true Foster Kennedy syndrome. Olfactory groove meningioma or anything like that will produce a Foster Kennedy syndrome. Pseudo Foster Kennedy, of course, it can be due to AON. So, yeah, this is the components of, okay. So, symptoms of papilledema are very minimal, unlike papillitis. You can get transient blurring of visions due to vascular problems. When it causes optic disc problems or nerve problems, you get a constriction of peripheral field. Then you can get your enlargement of blind spots sometimes. Then if optic atrophy is setting in, central and centrocecal scotomas. But other symptoms would be primary to the lesion, headache, vomiting, and all those things will be there. So this is very important. And diplopia, even 6 nerve palsy can cause diplopia. This is the Cushing triad of raised ICT, an increased systolic blood pressure with a widened pulse pressure, bradycardia, and abnormal respiratory pattern. This is called the Cushing's triad in cases of papilledema. Right. Friesen's grading of papilledema, you call it, you have a small C-shaped halo, then a complete circumferential halo, then obscuration of one or more major blood vessels leaving the disc, then partial obscuration of major blood vessels, and partial or total obscuration of all blood vessels. So this is how it appears when you see the papilledema. Another classification is a simple, what is given earlier in Kansky and all those things, was Hoyt and Beeson classification: early papilledema, established papilledema, chronic and atrophic papilledema. Here you can see blurring of margin, mild blurring. Venous pulsation will be absent. Normally, 15 to 20, 30% it may be absent in normal. But if you give pressure, you can elicit the venous pulsation. So these are spontaneous venous pulsation will become absent. Here you can see that. Okay. You can see the venous pulsation really. Actually, we see it when we see the disc regularly. So the absence of it is a significant finding. Established papilledema will be hyperemic, full blurring will be there, disc will be elevated, retinal veins will be engorged, and this is full blown. It will be more than 3 days diopter elevation. Chronic is called the vintage papilledema, champagne cork appearance. It will be more pale, it will be elevated, mushrooms into the vitreous cavity, hyperemia will be less, cup will be totally obliterated like this. So this is the grade 3. And atrophic will be totally pale, margins will be blurred. So when you have margins blurred and paler, you think about something called a secondary optic atrophy, post-neuritic and post-papilledemic. So later stages, it may be difficult to differentiate post-neuritic and post-papilledemic optic atrophy. So blurring will be there in both, but if you see the post-neuritic type, the vessels will be narrower near the margin of the disc. Whereas in post-edematous, it will not be. So that narrowing of vessels near the optic disc margin following post-neuritic optic atrophy is called reverse tapering sign, reverse taper sign. So that is one differentiating point. So this is one case where you have the secondary optic atrophy. So this is called benign idiopathic hypertension. So bilateral papilledema, raised ICT, ventricular system should be normal or small, but not enlarged, and CSF study will be normal. The way we go about treating is depending on whether it is symptomatic or non-symptomatic and go on. So any investigation for papilledema should be starting off with your first optic nerve function, basically your vision, then your color field, visual field. That is very important. But the major tendency of testing the field is only 30-2 or a 30-degree field. So what happens is, for papilledema it's okay, but one thing we remember, only if the periphery of the nerve is involved, getting affected, then your 30-2 will be now. For example, optic neuritis, if there is, as I said, axial, periaxial, transverse and perineuritis. In perineuritis, we may miss 30% of the field effects if you don't do a full field in cases of optic nerve problems. Only central field, maybe the major bundle is central field, but perineuritis and all, we will miss out on the visual fields. FFA, yes, to differentiate between, not really necessary. Papillitis. In papillitis, you will get a patchy hyperfluorescence. In papilledema, you will get a generalized hyperfluorescence. So, enlargement of blind spot, centrocecal, all this will occur in the later stages of papilledema. So, here you can see how a bilateral papilledema, actually this patient had multiple, thousands of cysticercus cysts all over the body, including the brain. Postpartum, she was referred for a headache, and this was the finding in both the eyes. And then they did the MRI, they found complete, and they couldn't save, it is not possible. Cystic neuro and skeletal. So this is the diffuse hyperfluorescence of papillary edema. So then management is nothing but treat the cause. The primary cause has to be treated, space occupying lesion has to be involved or treated or whatever, and we have to follow up the eye to look for any compromise on the visual functions like fields and color vision and visual acuity. So when you think it is the treatment of the primary cause, removal of the cause, if they are not able to remove the cause, they will do a shunt, ventriculoperitoneal shunts or whatever shunts. But when it is beginning to affect the eye, then we need to do our local intervention and do a nerve sheath decompression. This is called De Vickers technique. Approach could be medial, anterior, lateral, or even translate. It can be done. Ultimately, when we make an incision on the nerve sheath, what happens? These fluids will come out and release the papillary edema. On the table, we can see some changes, vascular changes occurring. So our role will be when it is affecting the vision, we need to change the eye function and we need to intervene. That is where this is translate approach to doing optic now. Now the difference between, differential diagnosis, so many things can mimic a papillary edema. For papillitis, it is hypermetropic disc, then drusen, a congenital anomaly, hypertensive retinopathy, diabetic papillopathy, and so on. Most important is, as we said, sir said, there are so many differences between papillitis and papillary edema. Unilateral, acute will be papillitis. Papillary edema, except if it is trauma, hemorrhage or something, it will be insidious. Laterality, papillitis will be unilateral, bilateral. Early symptoms, late symptoms. Painful, painless. It has already been explained by sir. Pupil can be having RAPD, depends on the primary lesion, vitreous haze and like this. Next is venous engorgement will be more in papillary edema. Most of the findings are relative findings. This and this may be overlapping. So fields, peripheral constriction, all central scotoma and all these things will occur. Late only the fields will show up. FFA, I said, patchy hyperfluorescence and diffuse hyper. And if you do a B scan in papillary edema, you will get a crescent sign. India B scan. So very rare test is you do a AC tap. In papillitis, you will get cells in the anterior chamber. In papillary edema, you will not get. So these are some of the exam they can ask. Don't tell Seldinger's test first. You can write in your exam, but these are the about 14, 15 differences are there. So this is an overview about papillary edema in all. Thank you so much for your hearing and thank all my speakers. Thank you. Now I invite Dr. Kalaimati Madam from Giridhar Eye Institute to give a talk on optic atrophy.
Thank you, sir. Good evening, everybody. My topic is optic atrophy. If you see a optic disc like this, unilateral or bilateral optic atrophy like this, how are you going to proceed? First, with the history itself, the etiology of optic atrophy can be found out in 92% of the cases. And if the optic atrophy is unilateral, and if the patient is young patient, the diagnosis is the cause for the optic atrophy is optic neuritis, that is inflammatory. And if it is a unilateral optic atrophy and the patient is relatively old, the cause for the optic atrophy is inflammatory, that is it could be anterior ischemic optic neuropathy. And if it is bilateral, the cause for the optic atrophy could be nutritional, Leber's, toxic, hereditary, or could be because of idiopathic intracranial hypertension. So if the cause for the visual loss is sudden, then we have to think in terms of vascular etiology, and if it is subacute, then we have to think in terms of inflammation. If the visual loss is gradual and progressive, we have to think in terms of compressive or nutritional etiology, or if it is static, we have to think in terms of ischemia or trauma. So past medical history is very important in bringing important in diagnosing the etiology of the optic atrophy. History of infections like TB and syphilis is important. History of any trauma, surgery, and history of any intake of medicines like ethambutol should be asked for. And any substance abuse like alcohol, tobacco should be noted. And any systemic diseases like hypertension, diabetes, myocardial infarction should be noted. So, a comprehensive ophthalmic evaluation should be done starting from best corrected visual acuity, color vision, pupillary examination, slit lamp examination, and optic disc examination is very important. It gives clues regarding the cause for the optic atrophy. For example, if there is cupping, then we can think in terms of glaucomatous optic atrophy, and if we have to examine the optic disc of the other eye also. For example, if the other eye optic disc is small and a cupless disc, then we have to think in terms of AION in the affected eye. If there are optociliary collateral vessels, then we have to think in terms of optic nerve sheath and meningioma. And if it is a bow tie atrophy, then we have to think in terms of chiasmal lesions. So, in any case of disc pallor, you have to examine under magnification and under green filter. Then go ahead with the ancillary testing like automated perimetry. And if it shows any central field defects, then we have to think in terms of nutritional or toxic optic neuropathies. And if it is hemianopic field defect, then we have to think in terms of chiasmal or retrochiasmal space occupying lesions. And if it is altitudinal, we have to think in terms of ischemic. Then go ahead with MRI brain and orbit with contrast with fat suppression. And in case of optic atrophy, 20% of the optic atrophy is because of compressive lesions, which could be detected by MRI. And if MRI is negative, then go ahead with blood test like syphilis serology and quantiferon TB, chest X-ray, etc. And finally, you can go for genetic testing for LHON and dominant optic atrophy. Coming to the cases, 57-year-old male coming with history of blurring of vision 3 years duration, vision right eye 618 and left eye no PL, RAPD left eye, color vision right eye defective. This is the both eye optic atrophy. We had sent for a MRI which came out to be both a bilateral optic nerve and optic chiasmal atrophy. Then when he came with the MRI report, only then he revealed the history of heavy smoking and drinking. So this is a case of toxic optic neuropathy. From the very history, we can come to a diagnosis of this optic atrophy. Straightforward case. The second case, 42-year-old male, history of RTA 4 months back, defective vision right eye, CT orbit fracture, floor of right optic canal, RAPD right eye, IVMP given, vision right eye PLPR inaccurate and left eye normal. This is the fundus picture. Again, this is right eye optic atrophy. This is primary optic atrophy because the disc, there was no previous disc edema, and the pathology is behind the disc. So this is primary optic atrophy. From the history itself we can make out it's a clear-cut case. This is a traumatic optic atrophy. Sudden diminution of vision, 3 days duration in the left eye, and diminution of vision right eye for 1 year duration. Smoker, vision both eyes counting finger 1 meter. This is the fundus picture. The right eye optic atrophy secondary to CRVO. This is secondary optic atrophy, secondary to CRVO, and you can see the disc margins are not clear. It's blurred, and because of the previous disc edema. So this is secondary optic atrophy. 57-year-old nurse came with diminution of vision, gradual onset, progressive in nature. Vision right eye 636 N18, left eye 660 N36. Both eye disc pallor. This is the fundus picture. Slow, progressive in nature. The history is diminution of vision, progressive in nature. She took ATT in 1995, developed diminution of vision, and after which ethambutol was stopped. So this is again toxic optic neuropathy. From the history we can make out, and this is again primary optic neuropathy because the disc is the pathology is behind the disc. 72-year-old male, vision right eye 6/6 N6, left eye 6/12, left eye RAPD, and both eye had slit lamp examination revealed both eye peripheral iridectomy, and he was on anti-glaucoma medications for more than a year. And this is the fundus picture. Right eye was normal, left eye was had optic atrophy. So from the history we can make out that he had glaucoma. So this goes, the diagnosis is glaucomatous optic atrophy, and this is cavernous optic atrophy. And the ancillary testing field is confirms the diagnosis. This is cavernous optic atrophy. 62-year-old male, blurry vision both eyes, difficulty seeing at night, no family ocular history. Vision right eye 6/18, left eye 6/9. This is the fundus picture. This is a very clear-cut case. This is a consecutive optic atrophy secondary to retinitis pigmentosa. 33-year-old female, headache 2 years duration, vision 6/6 N6 in both eyes, pupil normal, cycloplegic refraction done, slit lamp normal, fundus, both eye mild temporal pallor. She was called for PMT, and during the PMT color vision was checked because of the temporal pallor. It was normal, and she was given glasses, plus 0.5 glasses was given. And this was the fundus picture, bilateral mild temporal pallor. And she came back after 3 months with no improvement in headache. Again vision, color vision and pupil was checked. It was found to be normal. So we did a field testing in which the right eye had generalized reduction in the reduction in sensitivity. So we were not happy with the field testing. We ordered a MRI. It came out as microadenoma of the anterior pituitary. So we revisited the history. She had amenorrhea, and later on she developed galactorrhea as well. So she was referred to a neurosurgeon, and she was treated medically. So any even mild temporal pallor, you have to go for optic nerve function test, and if necessary do a field test is mandatory, and if necessary can go for MRI. 69-year-old female, defective vision left eye 1 month, defective vision right eye many years. Right eye 6/9, left eye 6/12 N8, color vision left eye defective. Fundus right eye pale disc, left eye disc edema. This is the right eye and pale disc, left eye disc edema. This is the right eye disc edema in 2013. Okay, so now the status is right eye pale disc because of the AION in 2013. And in 2013 the left eye was disc at risk, which was the disc was small with cupless disc. That is the point to be noted. And now that disc at risk has become developed AION now. And the second point here to be noted is the right eye pale disc has a vision of 6/9. So the vision and the pallor will not and does not correlate with each other. This is the altitudinal field defect. And defective vision 2 years, progressive in nature, right eye normal, left eye no PL and RAPD. And left eye optic atrophy, operated for sphenoidal wing meningioma. This is a primary optic atrophy because the pathology is behind the optic disc. Coming to the non-pathological causes of pale disc, if you examine the optic disc with bright illumination like indirect, the disc might look pale, and in case of any progressive myopia, the disc may appear very pale, and pseudophakic disc also appears very pale. So to summarize, systemic approach through history and examination, we can come to the etiology of optic atrophy. Automated perimetry is mandatory. Laboratory tests are useful only for specific diagnosis. Unexplained isolated optic atrophy imaging is necessary. Patients showing signs of progressive optic atrophy, frequent follow-up and re-imaging is necessary. And if non-progressive, follow-up can be gradually discontinued. Thank you.
Thank you so much, madam. Thank you all for staying back for the last session, and we'll end this session now. Any queries, we'll be happy to take directly. Thank you all. Have a nice dinner.